healthcare in the U.S.?
Somebody go around to our table. We have 4 students here. And
Just knock on the window, right in the corner.
get in here. They don't need to sit at the table.
So it's an honor really to speak in front of this group of activists. You are on the front lines, really making changes in our state and towards improvements for our society. I'm going to discuss a little bit about history, then we'll talk a little bit about possible remedies for the issues we face with healthcare. And I just want to remind folks that the system a nation uses that evolves in a particular country is an outgrowth from its history. So some of the slides I'll show you initially will be the American history as we understand what's possible and what may not be. Anyhow, who wants to answer who said these things? I bet we're going to get 3 out of 3 here. So millions of our citizens do not have a full measure of opportunity to achieve and enjoy good health. Millions do not have protection or security against the economic effects of sickness. So time has arrived for action to help them attain that opportunity and that protection. Guesses? FDR. Close.
LBJ.
Colder.
Truman.
Bing bang. Done. Are we any other awards? Or, okay. So that was 1948. That was Truman. Absolutely. And he was actually the first one to receive his Medicare card by LBJ, 1965. Next statement. Ballooning costs of healthcare is a hungry tapeworm on the U.S. economy.
Reagan.
A person who is wealthy and is the Wizard of Warren Buffett, correct. I forgot his nickname. The Oracle, thank you, the Oracle. Thank you. That was Warren Buffett. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Sorry, couldn't hear you. MLK, Martin Luther King, you guys are terrific. Nobody dies because they don't have access to healthcare. Who? Maybe, but no. No? Close. Back up a little.
Newt Gingrich.
After that, Raul Labrador, stumped you. All right. That was Raul Labrador from Idaho back with the Tea Party age and the initiation of the ACA. All right. So you may know many of these facts. We spend as a nation $3.5 trillion annually. Per capita, we spend $10,800 per person, more than twice the amounts paid in other nations. We are the number 1 in expenditure by GDP, 18%, and none of those countries are catching up very rapidly. The increments in healthcare spending consistently and remarkably outstrip inflation. So here's a graphic demonstration of this. You may have seen this slide. That's UK, that is a beverage-style nationalized health system at the top. Sweden is actually also a nationalized health system midway. Canada, you may be familiar with that in some of the talks this afternoon. France is a mixed bag. Japan, Holland, Germany, Switzerland doesn't even come close. If you look at how much we're spending per capita, this is a little dated now. This is 10,016, not 10,017. We are spending more than half of our expenditures on our public health systems. So this includes Medicare, Medicaid, CHIP, VA, Indian Healthcare Service, the ACA, and the rest of it is coming out of Americans' pockets for their premiums, deductibles, co-insurance, you name it. So it's the conglomeration of both that is leading to the expenses that we have. You are also aware personally, unless you're gray-haired, you have Medicare, you know how much your premiums are going up if you had an employer-sponsored insurance. So this is a graph of how those prices for your premiums and total growth in healthcare spending have been expanding since 2001. It's quite remarkable. When I was growing up, I was told, oh, the cost of your housing should be about 30% of your overall income. Well, now the cost of your health care is approaching 30% of your total income. This is pretty remarkable. As you might know, Americans worry, concerns financially about healthcare is their number one worry. It tops our worries about food, certainly. It tops our worries about housing. It is actually a level of insecurity that is remarkable. Our expenditures are triple that of inflation, by the way. So how did we get here? I'm going to give a few slides about history, and my colleagues will take some of that from here. We've come a little bit from George Washington's day when bleeding and purging was the mainstay of treatment. And if you survived your doctor's visit, you probably didn't need to see them to start off with. We now are in a role of heart transplantation, genetic modification, monoclonal antibodies, truly remarkable progress, and really wondrous care that some Americans are able to access. So we've moved along a little bit. This is Lister, you may remember, Semmelweis. This is before antiseptic technique. They've still got their hands, but they may have washed them. There's no cigars in the operating room, so this was progress, 1870s probably. So really, what happened in the late 1800s was the scientific method. People discovered bacteria. People discovered you could put bacteria into a person if you drop your cigar butt into their abdomen or whatnot. And so hospitals started to rise in their usefulness. They weren't just sick, poor alms places where people went because they didn't have money or died. Progress developed in modern medicine at the turn of the century. Around this time, the turn of the century, also, there was a progressive movement back then, 100 years ago. We're still at it. And these are the suffragettes. So there was some progress in bringing the vote to women. Of course, people of color had it and lost it, and that's another story. It certainly has a lot to do with discrepancies and disparities. It actually started on a local level. Blue Cross Blue Shield started in Baylor University in Dallas, Texas. And it was set up by 1,500 school teachers who were finding it hard to afford their hospitalization. They came together, a locally based group. They said, look, let's do something called prepaid insurance. This concept of, I'll pay a premium once a month and I'll get my health care taken care of. That was a novel idea at the time. That is actually transmuted, as we know, subsequently. So, we had the Great Depression, we had penicillin, this is Fleming, and looking at the origin of other modern advances way back when. We also had shipyards in California. That's Kaiser Industrial. You've all heard of Kaiser Healthcare, Kaiser Permanente. It was a large corporation in the 1930s that was having difficulty figuring out how to employ its thousands and thousands of employees. They came up with the concept also of a prepaid health plan. It was not supported, it was purely related to that industry. Only later did it develop to folks outside of the industry. So we had sulfa antibiotics. I think I can put this on. Please shut your cell phones off, please, during this speech. Okay. What's of importance, and that's critical to our understanding of how we came to link health insurance with employers, is the Wage and Stabilization Act of 1942. Are people familiar with this? Yeah, show of hands, people who know about this? Okay, so a lot of you guys are familiar with this. There was something called wage control. The government was very worried about inflation during the war period. So the government said, if you're an employee, if you are an employer, you must fix the cost of your benefits to your employers, to your employees. However, employers came up with a great idea how to attract some of their workers from other industries, or how to compete for workers at a time when they were scarce. We'll be able to add additional benefits. We can offer you health insurance. So So the government said, yeah, no problem, you can offer that benefit. You can't raise your wages, but you can offer them the benefit of additional health services, basically health insurance. And that was the origin, actually, in the US. The IRS ruled that's fine. That was the origin of how in America we linked insurance with one's employer. That makes sense? So those were the war years, interesting times. We survived that, and subsequently, this man, Harry Truman, in the lower left-hand corner, was the next president. He won 2 terms, barely. He tried to revise what was initially planned under the New Deal, which was a national health insurance. That quote by him was his efforts to actually have a nationalized health insurance for all Americans. 1948, it was the Red Scare. Stalin was in office, nuclear bombs ended the war, communism was the major worry for many Americans. It was easy to label nationalized medicine as socialized medicine, even though Truman and those proposals never had the US government owning hospitals or paying doctors directly. It was basically a health insurance plan guaranteed by the government. So it was struck down by a lot of the forces we'll see are at play. Even today, American Medical Association, the hospital associations, Big Pharma really didn't exist at the time, Chamber of Commerce, and a number of other groups in those days. But 1947, Britain did pass a more robust national health service. Also, the U.S. started to look at special groups that needed assistance. Our veterans who came back from not just World War II, but also the Korean War. The veterans had no mechanism for health care. If they were injured, they couldn't be working with an employer. They couldn't get health care that way. So, in fact, a nationalized health system was set up in the United States called the Veterans Administration. And we know that today as an example of a nationalized health service that exists actually in the U.S. Moving on a little bit, this is the late 50s, 1960s. We have something of an uprising by Americans who are starting to live into their late 60s, early 70s. Longevity is increasing during these years. No older folks typically are working any longer. They may not be well enough to do it at the time. There's a lot of young people in society. So there's a clamor to cover seniors on a health insurance system. It was a grassroots origin, it was real, and every representative heard it. Something else that was happening, we were starting to have things called dialysis. That was the first dialysis machine, a huge machine next to this individual. That was actually having to be triaged. You had 18-year-olds in kidney failure compared to 35-year-olds petitioning the hospital, can I have dialysis? I'd like to survive. Nobody knew how to pay for it. Dialysis was actually attached to the Medicare bill as a late addition. It was not part of the plan. What brought Medicare to the fore was public protest against the AMA. Many of you may have heard Ronald Reagan's impassioned speeches against the threats to our liberty by Medicare. Anybody heard those? They're amazing. They're on the net. They're quite remarkable. Anyhow, there's Truman getting the first Medicare card at the Great Society, 1965. LBJ got the Great Society passed. Medicaid was also a late addition to Medicare, by the way. Medicare was not envisioned to cover people in poverty. It was added on at a later stage of the process. So we were covering those folks who are quite vulnerable, the seniors and elderly, those who are not working, and the poor. Here we have, everyone can understand who these folks are. There's Nixon, and that's Ted Kennedy to the left. They actually proposed national health plans as well. It was not politically feasible. Something happened to Tricky Dick. He didn't serve out his term. But what he did accomplish was an HMO bills, a way to get funding for health maintenance organizations, which were looked at as a cost control mechanism. Ronald Reagan came into office after Jimmy Carter, of course, and the country had been through depression, a recession, It had been through long gas lines. There was dissatisfaction economically. We were in the doldrums. Something else that was happening during this period, globalization. Whereas 3 auto manufacturers in the US made the world's cars and stopped doing that in the 1970s. We had competitors. People were losing their jobs. The textile industry was moving overseas. Other heavy industries were moving overseas. Society was in a disruptive period. Ronald Reagan came into office promising to lift all boats with the rising tide. And he was going to do that through free market, using all the goals of free market competition, as you might remember from those days. So the deregulation of the health insurance industries came into play. And we'll talk a little bit later today in some of the sessions about how free market does not actually apply to healthcare, and I'm sure many of you understand that already. But during this time, mergers were occurring left and right. The you may be familiar that Blue Cross Blue Shield in New Hampshire was allowed to become a for-profit insurance company called Anthem. Endowment for Health actually was a spin-off from the funds that were provided by Anthem to be able to become a for-profit health insurer here in this state. Across the country, you had what are currently United Healthcare, Humana, Cigna, WellCare, Aetna, a variety of other major corporations. They consolidated, they monopolized, and they became the big players. So that sort of brings us up to today in our healthcare costs and our costs being extraordinary. We're going to get to that a little bit more. This is a slide that's important, which demonstrates in this day and age, we have 30 million Americans who remain uncovered by any healthcare plan. We have 40 million Americans who are underinsured. Their insurance will not cover them if they get ill. So here are all the various tandem parallel public health programs. There's Medicare, as we discussed, Medicaid, SCHIP, Medicare Part D, tacked on in 2003. As you all know, Medicare Part D was, as was the ACA, essentially drafted by the lobbyists for Big Pharma and the health insurance companies. Medicare Part D, as you know, prohibits the federal government from negotiating with drug makers. There's no direct negotiation that's allowed. And again, the ACA was a real improvement in terms of many folks who are left between the cracks. Covered 10 essential benefits, no denial for pre-existing conditions, which is one of its major issues, but the major issue is expanding Medicaid, as you know. And this is a graph of the number of uninsured, that's 1987, that's still the Reagan administration, to 2008 prior to the ACA. And it declined from 30 million uninsured to 46 million uninsured. Many who were not people people of color, people who were in underserved areas. This was middle-class white America, which really was feeling this pinch. And so there was clamor from the usual political forces to do something about it. And you may remember the Harry and Louise commercials. Anybody remember those commercials? Sitting around at the kitchen table. This was Clinton's efforts in the White House. That was after '88 and with the initiation of the Clinton years. And that was struck down. However, we did move on to the Affordable Care Act. We'll talk a little bit about that. This is insurance premiums, just another illustration of what's been happening. Not ancient history anymore, local history since deregulation. That bottom blue line is overall workers' earnings. The green line is overall workers' earnings. The blue line is inflation. The red line is insurance company premiums. Clearly, a lot of economists, by the way, believe that one of the reasons, that line is actually flatter now between 2008 and 2019. Wages, low-income wages have actually stayed flatter than that. And many people believe that is because they're, I know from personal experience, yes, I want to keep my health plan. I got to do it for my family, a teacher or whatnot. I'll take less pay, or I'll be willing not to get a salary increase. Please keep my premiums. Please support my health care. And there's good evidence that that's what's been happening with this ongoing disparity between people's incomes. Here is just another representation of annual premiums for single and family coverage. That top bar is $19.99, $2,000 for single. I think it's $7,000 on the top, $2,000 and $5,000 it looks like on the top for family coverage today, $18,000 for family coverage overall, $7,000 for individual coverage. That's just the premiums. That does not include your deductibles, which is a new phenomenon in American healthcare. Who cares? Well, the ACA did help lessen bankruptcy. There's some good things that happened with the ACA. In the past, by the way, most people who became bankrupt in the U.S. had a health insurance. It was just not very helpful. It was not particularly protective. And this is a slide I wanted to show you. So the ACA, which in my mind was a dinghy, a lifeboat attached to a leaking ship of healthcare in the U.S. People could climb into that dinghy, and a lot of people did. And actually, this is a number of uninsured 2008 up to when the ACA became incorporated 2014. You see that steep decline, such that as of 2017, there's only 11% of Americans don't have insurance. Unfortunately, that percentage is now climbing again with some of the encroachments on the ACA. And also with medical care becoming increasingly unaffordable. So I think this is just one last slide. Who do we have who's left out? What exists today? Clearly, those who are not old enough and those who are not poor enough. And I hear this from my patients. I see this from my patients all the time. People who come in and say, you know, I'm not poor, I'm working 3 jobs so I can have this income, but you know what, I still can't afford health care. And yet, people are upset that there is benefits for a human right for people who clearly do not have the income. And of course, when you're 64, a lot of my patients will save up all their medical problems hoping that they don't have a heart attack or a stroke or some other catastrophe in the year until they can climb on to Medicare. The other folks, of course, are those in the gig economy, people who are self-employed, do not have a large employer, they have the health literacy and the ability to navigate the system, they just cannot find the income to support, to use the exchanges in the ACA. See a lot of people, many of the people who become our most costly patients, both in health as well as expense, a lot of folks who have many social determinants of health impacting on their health, who don't have the wherewithal to be able to navigate a complex American medical system here in New Hampshire and Vermont. They don't have the wherewithal, they also don't have the time. They're working 2 jobs, they're taking care of their mom, they're taking care of their grandkids, or they're taking care of their own children. They don't have time until they end up in the emergency room with a health catastrophe. And this is a reality. We see this on a daily basis, in this state and next door. High deductibles, we'll get to Trump care. What's promised with Trump care? High-risk pools, a wonder of the 2000s, which didn't cover anyone, was unaffordable for everyone, and junk insurance. So stay tuned if that should ever come. Seniors with their long-term care needs and undocumented immigrants are some other groups who are currently uncovered. But it's a complex system, an extraordinarily expensive system, with poor value for the health care dollar we expend. So with that, I'll leave this slide up, and Sandra will take it.
So we want to go a little bit through the background and history of kind of how we got to where we are, because I think it's really important to know that part of the conversation, especially as we're talking about where we want to go from here. And we're going to hear a lot this presidential primary season about what are some of the policy options. Every major candidate has their own policy proposal out where they're talking about the ins and outs of what they would like to do if they were elected and had the next administration. So it's important to kind of have that context. And the types of options we see kind of fall into 4 different categories. The first is to fix and expand the ACA, so often known as ACA Fix-It bills. These are things to fix things like surprise medical bills, to make sure that those who are in the Medicaid expansion population, which, as a reminder, because of the federal lawsuit around the Affordable Care Act, states actually had to vote to adopt that program. New Hampshire thankfully has and has reauthorized, but now we have a really damaging work requirement as part of it. So that type of activity, or expanding who can qualify for different portions of the ACA, like expanding public plans and public options. The second category are folks who are looking to expand eligibility of other age groups into Medicare or Medicaid. And we've got some proposals we'll go through in a second and talk about kind of where people fall in the age range. Option 3 is all payer rates, so same rates apply to Medicare and private insurers. And then option 4, which is kind of where a lot of the conversation has been, is around the single payer. And we'll know that that's the most disruptive, but probably when it comes to cost and quality is also the one that we'd have the most control over. And as part of our conversation today, we want to explore what those different options are and how people are approaching it, and then have a little bit of a community conversation about what are your questions as you consider which type of policy proposal you would most like to advocate around, and what are the things that you need to ask the questions of those presidential candidates to make sure that we're not just fighting for a particular policy, but we're really fighting for, this is why we titled it this way, universal health care. The goal is not one of these specific policies that's been presented, but the goal is to reach getting to coverage that everybody has access to quality, affordable health care coverage that really works for them, so we don't end up with those things like people having coverage but not actually being able to utilize it. So I'm going to ask Dr. Kolish to lead us through some of the different proposals, and there are a lot of details in these, so I'm going to reference 2 things. In your packets it's a very long document with details about each of the really major policy proposals we have out there. It's again, very long document. It's also very small print, but we do have a link to it off of the New Hampshire Progressive Summit website, so you can download that and enlarge that as you look through it. And then there are some other resources that we'll mention at the end of this as well. So, Doctor.
Can you remind me how much time we have? Okay, so,
Just a quick note for folks, we are going to start the next session about 10 minutes later for the transition, so that you'll have plenty of time for those workshops.
who knew that healthcare could be so complicated? It isn't a moonshot, I agree, but there are a lot of moving parts. And as we talk about the different proposals, I want you to keep in mind the big parts. So these are the things to look for. The first is, how is the healthcare delivered? Does the plan define how it is delivered? Who are the providers? Doctors, nurse practitioners, are they the hospitals? Look for that. The second thing is, how is it paid? What is the role for commercial, for-profit insurance companies? What is the role for non-profit insurance companies or insurance companies that are regulated? What is the role for state funding? What is the role for federal funding? And how much is self-pay? How is it delivered? How is it paid? And then the third big piece is, how is it managed? Who runs the system? Currently, the system is a marketplace. Is it still going to be a marketplace? Will there be health commissions, such as in Vermont with Green Mountain Care Board? Is government going to run it? Will pharmacy benefit managers run it? And so when you think about these issues, you have to think about issues of trust, because this is a complex problem. And as the presidential candidates come by, you have to decide who you trust to get it right. So when you look at the people who are sponsoring these bills, the ones that are in your packet, ask yourself, what is their knowledge base? Who advises them? Who are their health policy advisors, and where do they come from? Who donates money to them? Shall I repeat that one? Who donates money to them? And how have they voted in the past? And the reason this is important is because now how many candidates are there? Okay, 20? Can't count them. They all say universal health care. I like Medicare for all or something. The devil is in the details, and at some point you're going to have to trust these people to get the details right. So the things that I look for as we're about to look through the plans. Number one, is the plan fair? Healthcare, my friends, is a right. It is not a privilege. Okay? Is the plan fair? Does it cover everybody? Everybody in, nobody out. Is it related to age? Does it cover people from all socioeconomic brackets? The second thing, does it cover all essential services, and this must include reproductive services for all, and it must include long-term care for the elderly. Is it fair? Does it cover all essential services? Number three, roles for the insurance companies. The insurance companies must either be gone, or they have to be very sharply regulated and controlled, as they are in Switzerland and Germany. Because once they get their nose under the tent, the rest of the camel will follow. Pharmaceutical companies must negotiate prices. They must not be in charge. And finally, the one that is often left off of the list of musts is that hospitals must have global budgets. And this is a detail that policy wonks keep off of the list, but I urge you to look for this. Our fire departments, our educational, our schools, we do not do this as a pay-as-you-go. They submit a budget, we vote on it, and then they must provide the services and the care within those limits. There must be global budgeting for hospitals. Those are the 5 areas that I urge you to pay close attention to these plans. Fair, cover all essential services, insurance companies, pharmaceutical companies, and hospitals must have global budgets. In sum, what makes our healthcare remarkable in the world, and the reason that people can get away with saying that it is the best healthcare in the world, is because, probably, we think, because the innovation that is stimulated by private delivery systems. We have wonderful delivery systems. We have wonderful nurse practitioners, physical therapists, doctors. And we must have public funding. Private delivery, public funding. Look for it in these plans. Now, does everybody have that how many pages? 8 pages. Okay, open it up. We're going to go. No, we're not. The thing to ask as you look at the plans, the only one that I think of as being Medicare for all is the last one that Zandra put up, which is single payer. That is truly Medicare for all. The other ones, either the public option, and there are a number of bills. Merkley bill, the Schakowsky bill, which is Healthcare for America. Those are, and this may be politically better, Medicare for some, not Medicare for all. People 65 and older will still automatically get Medicare, will be eligible for it. People under the age of 65 will have the option of buying into Medicare at a controlled premium rate. There are other Medicare options which simply lower the age of eligibility, which, to my way of thinking, is a good way of transitioning. I think we probably could do it like that. But if you must transition, go from 65 to 50, and then from 50 to 26, and then you got them all. Okay? The Medicaid public option introduces a level of confusion because Medicaid is, as you all probably know, a combined match program between the states and the federal government. And so then if you buy in to Medicaid on a state-by-state basis, then you've introduced 50 new insurance programs that the federal government is sponsoring. Almost all of the different plans, and you can look at the details, are either Medicare for all, Medicare for some, or stupid. Reject the stupid, look at the Medicare for some, and see if you think, and I'm not a politician, I do not know, as many of you do, about political expediency. When I go down to testify in Concord, and I've also had the opportunity to testify in Washington, I don't know how the sausage is made, and I find it to be upsetting. But if you're going to promote a plan that is Medicare for some, be damn sure that you're not trading political expediency for fairness and affordability. Very briefly, I'm a family doctor. I started off my practice in the North Country, so my love is in rural New Hampshire. I now practice at the VA, which is a single-payer system. I've come to believe that that's the kind of system, a single-payer system, I apologize, not VA, I don't want VA for everybody, what a mess. But a single-payer system, I personally believe is the way to go, and I look forward to answering your questions.
Tim's going to come around to the microphone, but as he's making his way over, I do want to ask just one question to kind of kick us off, and that is, there's going to be a lot of pushback, obviously, from those who are opposed to healthcare in general. But the biggest one that we hear from people all over the political spectrum and ideology is the cost around some of the healthcare options. So I just want to ask you both to comment on that briefly.
See if I can get this working. So, any of these proposals in front of you are going to be disruptive to this 1/6 of the U.S. economy. Any of them. Any proposals that will be instituting regulation or a change in our current system will improve our current costs as well designed. The problem is in the pudding, how you're designing. So in terms of what you'll hear is that, oh no, this is too, you're not going to find your doctor. It's hard to find a primary care doctor today. What you're currently seeing in terms of costs, that exploding exponential rise in costs is not just because of lack of regulation per se. It's because of something we call pricing failure. That is, there is negotiations that are happening behind closed doors. They're opaque. They're often happening between your insurer, the pharmaceutical industry, a pharmaceutical benefit manager, There's a lot of negotiation that's happening. It's just you're just not aware of it, and it's feeding into profit. So we have huge costs. We saw on the slides how we compare to the rest of the world per capita. And this is not based on age of our population, by the way, or morbidity of the people who are recovering. It's based on our current system. So when you hear, oh, it's going to cost $32 trillion in a decade, guess what? You save $2 trillion by changing to that system versus using what we have right now. And the more important issue is Americans will be paying less money for higher quality care for individuals. People who will not be doing as well are CEOs who are making huge profits because the system is geared towards profit. So that is the reality when you hear issues raised about cost.
Thank you, and thank you for the attention that both of you just made. I spent 17 years in Germany. I went there as a minor, and I left when I was married and working in Germany with a family of 2 children. So I went through the healthcare system in Germany for 17 years at different levels. And I want to tell you that I got high quality healthcare, I got affordable healthcare, and just one comment about the cost. When you put up the cost initially, what we're paying, I assume that that cost does not include long-term care, which we don't have in this country, which the countries have, and it doesn't include the additional costs that we have on our medical riders, on our home insurance and car insurance. Those are things unthinkable in Europe. People don't even think of that because that's all included in that price that you just quoted. So you should make sure you include the cost of long-term care and the other riders on our healthcare system to show the real cost. So no, that was the one comment. Then, in order to just underscore what Germany and other countries do, is they use a market-based system too. Some of them are run by the government, but most of them, like Germany, are market-based. And the way they do that is they say, number one, by law, everyone has to have health insurance. You have to be in the system. You cannot be employed, you cannot hire anybody who's not in the system, period. Number two, it's regulated like a utility. They say healthcare is like water and services, they have to be regulated, and they are regulated, and despite that, doctors like you in Germany are driving Mercedes, nonetheless. So that's what they do. Number three, they manage their cost. So every year there's a healthcare council in Germany gets together and says, what's the basic package that has to be provided, and how can we provide it in an affordable way? And that's modified every year. And finally, affordability. They don't say what the premium is, they say how much % of your income are you allowed to pay for that? And in Germany it's about 7% that you have to pay, and your employer has to kick it in, but you are the owner of your healthcare insurance and not your business. But that's how they manage to do this. So it's not nothing you can win a Nobel Prize for discovering anymore. It's been done.
I would just like to make a brief pitch. My name is Adrian George. I belong to Rights of Democracy. In July 13th, there's going to be a Medicare for All public forum. It's going to be held at St. Anselm's Institute of Politics. And our main speaker, Barbara Farley from the Political Economy Research Institute, just came out with a very detailed study of the economics of Medicare for All. It will answer a lot of the questions that were alluded to, but in great detail. And also Michael Leahy, who's the former National Nurses United president, will also be there. Anyway, I really encourage you to come to that forum.
I'm actually going to pose a question, and I just want to put it out there for anybody unless want to answer, or anybody from the audience. But how many people here were part of the Affordable Care Act, right? Raise your hand. Oh, more of you helped with the Affordable Care Act than you raised your hand. How many were here for the Clinton healthcare fight? I just want to ask us to think about, as we're trying to figure out kind of where we each go and how we use this presidential primary season, what were the biggest challenges you felt like we had during those fights? Because, you know, we all in this room agree about the concept and goal, I would hope, around universal health care. The reality is when the rubber hits the road out on the field, and thank you for bringing up the forum, because that'll help folks who want to pursue that policy be able to talk a little bit about it more. But the reality is we're going to face a lot of opposition, and the opposition hasn't geared up yet. So while we take Bob's question, I just want folks to think about what are some of the learning lessons that you think we have from the Clinton years, from the ACA fight, that you want to make sure that we're prepared for going forward?
One of the concerns I have is the accessibility of the present healthcare system. If you're poor, you don't have access and you die. If you're rich, you got lots of money and lots of care and maybe you're rich. But the Medicare for all is the one way to equalize that equation. But I want to put something else on it. Presently, there are all kinds of people and all kinds of ideas to run the system. I think it is a system that is to be run by medically trained people, doctors, physicians assistants, nurse practitioners, nurses, nursing assistants. All of these people make up the healthcare personnel. They should be the ones running the system, not the insurance people or for-profit system. Because I do not believe that we need to profit on human life. Your counsel.
Thank you, Bob. It's interesting, why Medicare for all, and Dr. Colliston alluded to this versus Medicaid for all. Why not one versus the other? Apart from the fact that Medicare is transportable from state to state. It's a universal system for all Americans, but it's also universal for all Americans at a certain age. It's not based on what your income was, what you did for a living, whether you were a veteran or not, or whether you were a CEO, who knows what. It was felt that all Americans are not entitled, they're human. This is a human right. So this is something that we provide to Americans. There is a lot of stigma attached to Medicaid. If you think about our lives and what we've heard about insurance programs of other natures. Medicare has its historical roots with Social Security. So who here wants to have their Social Security? That's part of being an American. It's an institutional process. So when you hear people, and I hear it today, I hear it in Congress. I hear congressmen say, keep your government hands off my Medicare. That's bizarre, but we'll hear it. And so I think your points about what the intent is of a particular plan, who is organizing it, who is supporting those hospitals that are going under in rural areas and allowing other hospitals to flourish on their own. There's so many issues about the need for government intervention, so thank you.
Hi, I'm Matt Murray. Everybody's taught me already. I'm also a type 1 diabetic. I was diagnosed late in life and everything else. So there's been a lot of media coverage, especially lately, about the high cost of insulin. But what isn't discussed is the high cost of managing your diabetes in other ways. I have to provide for supplies for my insulin pump, needles, test strips, all of those things. Where does that fit into a single-payer system as well? I'm not old enough to get into Medicaid, so I don't know how the coverage is. My medical insurance is pretty decent. I spend probably $400 every quarter just on insulin and supplies, which is really, really good comparatively. But where does that system fit in with people like me? Because it's not just the prescription drugs that I'm worried about. It's the other costs that I have to deal with.
Thanks. So the way things stand currently is that if you are on Medicare, and all you have is Medicare, then you have to pay for all that on your own. Medicare for all, which I think most of the policy people call improved Medicare for all, would include all essential medications and supplies. So it would be somewhat similar to those of you who have Medicare A and B and D, which covers most drugs and supplies, but it would not have the so-called donut hole, which is this weird thing that happens to people who have Medicare Part D, where it covers up to a certain level, and then pays nothing for $2,000, and then it kicks back in. So the bottom line is Medicare for all would cover your supplies.
One more thing about glucometers and glucose testers, your test strips, it's pretty remarkable. When someone changes their job, they get a new insurance, you gotta start from scratch. So you learn how to use a glucometer, you've got all these supplies, you've got all the testing equipment. You have a new job, you have to start from scratch. I can't tell you how often that happens. If there's any delay in insurance, why is that happening? Because there is negotiation going on between the insurance company, the pharmaceutical benefit manager, the makers of these products, but it's not regulated. It's catch as catch can, it's profit directed. So no question, as Dr. Koller said, we really do need to have these things covered in the Medicare, and that will be in any of these plans. Actually, all of the plans in front of you, almost all of them, have an expansion in the benefits that are covered.
With that, I got the queue. I know we got a couple other questions. There's actually going to be a workshop, the last workshop block. These fine gentlemen will be participating in. So for those who have additional questions, you can find them throughout the afternoon or join that workshop block on the Medicare for All campaign at the end of the day. I'm just going to go back real quick and answer that question I posed a second ago as the former communications director for New Hampshire for Healthcare. Which was the campaign that those purple healthcare voter stickers that were at presidential campaign events in 2004 and 2008 that got President Obama to commit to making healthcare a priority, and he did in his administration. I would just encourage folks to really spend some time, and I know it's wonky, but looking through these policy papers, take the advice of the gentleman up here about what types of things to look at in each of the proposals and what types of questions you should be asking the presidential candidates, because we're in a really pivotal moment around healthcare where despite all of the opposition and all of the debate over which policy path to pursue, as was stated earlier, healthcare is the #1 issue on people's minds. We have an opportunity to take this swell of energy and really use it to improve our healthcare system. If we're prepared as advocates, and I spent a lot of time in 2007, 2008, then through the implementation of the ACA, and then through the defense of ACA, which is ongoing, and trying to make sure that we had those answers, and so that we didn't get stumped when we're out in the field. Take one look at Americans for Prosperity and look at what they're talking about, and be prepared to answer those questions. So with that, I want to thank our panelists for their participation today.
Of other natures. Medicare has its historical roots with Social Security. So who here wants to have their Social Security? That's part of being an American. It is an institutional process. So when you hear people, and I hear it today, I hear it in Congress. I hear congressmen say, keep your government hands off my Medicare. That's bizarre, but you will hear it. And so I think your points about what the intent is of a particular plan, who is organizing it, who is supporting those hospitals that are going under in rural areas and allowing other hospitals to flourish on their own. There's so many issues about the need for government intervention, so thank you.
Hi, I'm Matt Murray. Everybody's talking already. I'm also a type 1 diabetic and was diagnosed late in life and everything else. So there's been a lot of media coverage, especially lately, about the high cost of insulin. But what isn't discussed is the high cost of managing your diabetes in other ways. I have to provide for supplies for my insulin pump, needles, test strips, all of those things. Where does that fit into a single-payer system as well? I'm not old enough to get into Medicaid, so I don't know how the coverage is. My medical insurance is pretty decent. I spend probably $400 every quarter just on insulin and supplies, which is really, really good comparatively. But where does that system fit in with people like me? Because it's not just the prescription drugs that I'm worried about. It's the other costs that I have to deal with.
Thanks. So the way things stand currently is that if you are on Medicare, and all you have is Medicare, then you have to pay for all that on your own. Medicare for All, which I think most of the policy people call improved Medicare for All, would include all essential medications and supplies. So it would be somewhat similar to those of you who have Medicare A and B and D, which covers most drugs and supplies, but it would not have the so-called donut hole, which is this weird thing that happens to people who have Medicare Part D, where it covers up to a certain level and pays nothing for $2,000 and then it kicks back in. So the bottom line is Medicare for All would cover your supplies.
One more thing about glucometers and glucose testers or test strips. It's pretty remarkable. When someone changes their job, they get a new insurance, you've got to start from scratch. So you learn how to use a glucometer, you've got all these supplies, you've got all the testing equipment. You have a new job, you have to start from scratch. I can't tell you how often that happens. If there's any delay in insurance, why is that happening? Because there is negotiation going on between the insurance company, the pharmaceutical benefit manager, the makers of these products, but it's not regulated. It's catch as catch can. It's profit directed. So no question, as Dr. Feller said, we really do need to have these things covered in the Medicare, and that will be in any of these plans. Actually, all of the plans in front of you, almost all of them, have an expansion in the benefits that are covered.
With that, I got the cue. I know we got a couple other questions. There's actually going to be a workshop, the last workshop block. These fine gentlemen will be participating in. So for those who have additional questions, you can find them throughout the afternoon or join that workshop block on the Medicare for All campaign at the end of the day. I'm just going to go back real quick and answer that question I posed a second ago as the former communications director for New Hampshire for Healthcare. Which was the campaign that those purple healthcare voter stickers that were at presidential campaign events in 2004 and 2008 that got President Obama to commit to making healthcare a priority, and he did in his administration. I would just encourage folks to really spend some time, and I know it's wonky, but looking through these policy papers, take the advice of the gentleman up here about what types of things to look at in each of the proposals and what types of questions you should be asking the presidential candidates, because we're at a really pivotal moment around healthcare where despite all of the opposition and all of the debate over which policy path to pursue, as was stated earlier, healthcare is the #1 issue on people's minds. If we have an opportunity to take this swell of energy and really use it to improve our healthcare system, if we're prepared as advocates, and I've spent a lot of time in 2007, 2008, then through the implementation of the ACA, and then through the defense of ACA, which is ongoing, and trying to make sure that we had those answers, and so that we didn't get stumped when we're out in the field. Take one look at Americans for Prosperity and look at what they're talking about, and be prepared to answer those questions. So with that, I want to thank our panelists for their participation today.